Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week we had another episode of Research Roundup. We brought back our guests Dr. Bincy Abraham and Dr. Jami Kinnucan. Dr. Abraham is the Distinguished Professor and Director of the Fondren Inflammatory Bowel Disease Program at the Underwood Center for Digestive Disorders at Houston Methodist Hospital. Dr. Kinnucan is a Senior Associate Consultant in the Division of Gastroenterology and Hepatology at Mayo Clinic in Jacksonville, Florida. She's nationally known in the field of gastroenterology and in particular her specialization in the evaluation and management of patients with IBD. They just recently attended Digestive Diseases Week, which is a huge conference that covers a lot of different diseases. We talked to them about the different themes that they saw at this conference, including evaluation techniques and monitoring techniques for inflammatory bowel disease that are new medications that are coming down the pipeline, dietary changes, and many, many other things. We had such a great conversation. Cheers.
Hi, everybody. Welcome to Bowel Moments. This is Robin.
Hey, guys. This is Alicia, and we are so excited to be talking to our two guests today. We are bringing back Dr. Bincy Abraham and Dr. Jami Kinnucan. Thank you, ladies, for coming back on the show. We're so excited to have you.
Thank you so much. It's always wonderful to talk to you both.
Well, we love seeing your faces as well. Unfortunately, the guests will not. But the reason we brought you back is because you guys just recently attended Digestive Disease Week. And so we wanted to talk to you about all of the things that you learned that were exciting and new for patients. So I don't know if I want to ask you this, but what was your favorite cocktail you consumed while you were at DDW, since none of us can actually drink because we're still functional adults right now?
I actually trialed a new cocktail. So as you know from our last podcast, I like to, experiment with different cocktails. I forget what I was drinking on the last podcast that we did.
A Naked and Famous. I remember it
Naked
well.
and Famous. You do. So there was one that was a smoky based cocktail with a tahini rim that was at the hotel lobby that I was staying at. That was quite delicious, and it came with a little orchid flower in it. And I will find the name of it, but it was a quite delicious, different type of cocktail. I only consumed one during my whole stay, so it was really tame in that.
It sounds lovely.
It sounds very unique. I'm very curious about this now. Bincy, what about you?
I don't remember the name of it, but it was at a sushi bar, actually in the Trump Tower, and it was actually a nice, restaurant, and they were actually famous for their cocktails. I don't remember the name of it, but it was
16. It was on the 16th floor, yeah?
I believe so, because we could look out to the water.
Yeah, it was beautiful.
Yeah, and there was one that they had this cloud, and it was like in this dome shape, and you touched it and it kind of disappeared, and it was like a fruity cocktail, but I don't remember the name, but it was good. It went really well with the sushi that I ate. Yeah.
That so fun. Yummy. Wow. Well, and Dr. Kinnucan, just as a note, because of you, we've now had to up our game, and I now own at least 20 more bottles of alcohol because of you, because I'm like, I can't drink wine in every one of these. So I've now started mixing cocktails, and so I have a lot more.
Everything in moderation, I think. And of course, I'm finding, I gave you guys examples of ones that it's very hard to get, chartreuse, which is how you make the Naked and Famous, because the monks have put a limit on the amount of chartreuse that they're making, and it's become so popular because of your podcast that now I can't get the bottle.
Oh, I'm so sorry we ruined it for you. Well, listen, if I could be drinking right now, I have gotten onto Aperol Spritz. Now that it's warm, I'm into the Aperol Spritz again. So, Robin, what about you? If you were drinking a cocktail, what would you be drinking?
If I was drinking a cocktail, I would be drinking, I'm in Florida. It'd have to be something tropical. Maybe I'm kind of feeling like pina colada-y right now. I would want something that made me feel like summertime.
Perfect. Well, so let's jump into DDW, guys, because one of the things you mentioned before we hit record was that there are some themes maybe that you wanted to talk about. So I'm going to have you jump right into the themes that you witnessed.
Some of the themes were really around diagnostics, and there were quite a few presentations around different biomarkers and looking at different genetics that can be used in both ulcerative colitis and Crohn's disease to be able to predict a diagnosis. Right? So before patients develop symptoms, are we able to identify patients that might be at risk to develop symptoms of ulcerative colitis and Crohn's disease even before they have a diagnosis, right? That's future state. And certainly there's a lot of work that people are doing on that. And it's imperfect right now, but there are some studies that had looked at different, sort of early diagnostics. There's stuff that we're using actually actively in clinical practice. And I'd love to see if Bincy's using this as well, that we can utilize prognostication. So there are certain biomarkers and genetics that patients with Crohn's disease have, and a test that's available through Prometheus that's actually paid for by one of our industry colleagues called CDPath, and it's developed out of work that Dr. Corey Siegel has done out of Dartmouth, looking at big machine learning, looking at patients' biomarkers, looking at different disease parameters that they have, and being able to predict what their risk is to have a complication in the next 3 years. And so that's something that we're using in clinical practice. And there were some, similar studies looking at different prognostication tools, right? So not all IBD patients are, created equal. They have, different disease courses, they have different severity of disease, and certainly they have different prognosis in terms of what happens to them over the course of their disease. And so, but yet right now we kind of group everybody the same as ulcerative colitis or Crohn's, and then we start you on, treatments, and we try to personalize as best as we can. And it's really where I see the field going. On that, there was actually this really cool study that they presented. It was the Emerald sensor, and it showed that they can use this sensor that looked at sleep, respiration, and I think it was gait. And they were able to see, just at your home, if you have Crohn's disease, and they were able to predict whether or not you were going to relapse based on looking at these different parameters. So it was using remote monitoring. And that's actually something that I'm really interested in is how can we almost, remotely predictive monitor patients versus sending you a questionnaire, you fill it out, we call you. This is using different parameters about things that are happening in your body and those predicting risk for relapse in the future. So some pretty cool stuff around kind of diagnostics and prognostic stuff. But I'd love to get Bincy's thoughts on some of those things.
Well, the CDPath, of course, is one thing that now, commercially we can use easily. I think traditionally, most IBD centers, the problem with us using any diagnostic markers that we already know how our patients did, because when by the time they're referred to us, our patients have already been through the complications, and we don't need a test to say, oh, you're going to have complicated disease. You already came with 2 or 3 prior surgeries and been on multiple medications. So I think this would be very useful for the general, GI practitioner, that has a IBD patient that comes into their clinic. Okay, and especially Crohn's patient, when we know there's risk of fistulas and strictures and things like that, how can we predict, for that patient, okay, how aggressive do we need to be? I think that's the whole point of being able to get that information for the future, is that if we're aggressive right now, then we can actually prevent all those complications, down the line. And if you have someone that, their pathways suggest, oh, this actually can be milder disease or maybe low likelihood for complications, we may not have to jump to, the next step or put them on, very strong medications right away. But on the other hand, if someone comes in and we have these predictive markers and they're at high risk, and we don't want to be waiting around, because you don't want to have that disease progress while we're waiting to see, oh, maybe we'll just wait to see your next lab work or repeat your next colonoscopy or repeat your next imaging, where you can just have like a guideline and it's there. And maybe in the future, we'll actually change the trajectory of our patients, follow up, and we may end up seeing, that's our hope actually, that with all of these new tests that we'll see less complications. The patients are actually appropriately treated. Now, take into account that, okay, insurance, agrees with all of our recommendations. We can get those medications on time. And of course, adherence to, therapy of what we, decide, of course, together with that patient as well.
Can I ask a quick question? In looking at these diagnostics, the biomarkers and genetics that would be used to see if somebody would develop inflammatory bowel disease, is there a type of person that you would give that test to? Like, is it somebody who has a first degree relative with this? Like, who would be getting these tests?
So it's interesting. So it's actually using machine learning, artificial intelligence technology, and using the electronic health record. And again, I'm not speaking to any specific study, and it's being done in different disease states. It's being done in pancreatic cancer. It's being done in celiac disease. It's being done in colorectal cancer, right? There are clearly things that we know that exist already in your chart. So let's give an example. If you were a patient that were seeing a primary care physician and you had diarrhea, for longstanding diarrhea and anemia, maybe the system would flag the provider to say, has this person been evaluated for inflammatory bowel disease? That's sort of some of those things. Whereas waiting for that person to become really, really ill, it's kind of like this higher level view of the record to be able to say, okay, this person has 5 of the 10 parameters that are at risk for developing disease X. We should maybe, nudge that provider. Should this person be screened? So in celiac disease, disease, if a patient has iron deficiency and a family history of celiac disease listed in their medical record, right, then that might be something that they would be more likely to be screened versus right now. So, but versus waiting for you to develop symptoms. So I think there's a lot of opportunities, to harness the data that already exists in records that exist about patients that are already diagnosed, patients that are not diagnosed. Wishful thinking future state is that we would know that you're at risk to develop disease, and then we could be preventative, right? And not at risk to develop inflammation because you already know that you have ulcerative colitis Crohn's, but you are, walking around and we know based on different biomarkers about you. So this might be lab testing, this might be clinical things about you, family history, genetics, that you are at risk. And so what are ways that we can do dietary modifications, avoid unnecessary antibiotics, do things that promote a healthy microbiome? How can we support you and be preventative versus, is the writing really on the wall? Or we all believe that environment plays a significant role in the development of disease in our patients with Crohn's and colitis. So how can we manipulate your environment to better support, prevention? That's kind of future state. This is like 2030 thinking, but I think people are publishing studies and putting them out there in the science that are really kind of thinking about some of these things too, which is really cool.
What about, you mentioned the Emerald sensor that looks at sleep, respiration, and gait, as in walking gait, for those folks who may not use the word gait in their everyday lives. What do we know about this? Why are these the things?
Well, I can tell you for sure, sleep is a big thing, right? For multiple things. We know that sleep, for example, if you're not getting enough sleep, it's not good for you. We know that in general for your entire physical health, mental health. It adds stressors to your body. And that includes not just like we talk about mental stressors, but increases your cortisol level. And we know that increased stress leads to an abnormal immune response. And so that can lead to flares and things, and also worsening of their existing disease as well. So I think sleep is one of the components. So it's not everything, right? Just like, with any disease, it's not just one specific trigger. It could be for a lot of different patients, but it's one of the components that we do need to kind of, emphasize. But again, if you have active inflammation, you wake up in the middle of the night, you're not going to get enough sleep either. So it's kind of this catch-22. So we have to get the disease under control. We have to get enough sleep in order for everything to kind of fall into place. So it comes down to, okay, well, we may not be able to fix everyone's sleep if their disease is out of control. So how do we work on that part with medical therapy or even surgery if needed for those specific patients, but get that under control so they can get more sleep. When sleep improves, then overall health and, body and mental health and physical health and immune health, improves as well. But the other hand, if there's something that you can actually control, let's say you're not getting enough sleep because it's a voluntary thing, you're, Netflixing, through, is that a word now? For watching Netflix movies till 2 a.m. and not getting enough sleep because you said, oh, this is my me time, and then that's going to affect your sleep. So there's something, there's that whole sleep hygiene component to it too. Yeah.
Yeah, and I think what it's just calling out is that, it's using a device and looking at things that are basically surrogates. So an excellent way that we're actually routinely doing this in practice is, so patients that have liver disease can develop confusion, and we call that hepatic encephalopathy. And so one of the first signs that they may develop sort of overt, meaning very, very clear clinical signs of hepatic encephalopathy, is if you monitor their sleep pattern, and just a variation or a change in their sleep pattern from when they clearly don't have encephalopathy, this confusion state, to when they do, that's the first sign. It's actually, the way that you can predict that they're going to develop it. So it's kind of the same idea. So, whether is it the inflammatory cascade in your body that's driving abnormal sleep parameters that are being measured by this device. I mean, there's work that I did in fellowship and Tasif Ali has done, really looking at the importance of sleep. And one of our previous fellows who's now in practice out on the West Coast, that sleep is important. Abnormal sleep is more associated with future active inflammation, even when right now you feel great, your disease is quiet. If you have abnormal sleep parameters or subjectively say that, I'm just not sleeping well, it can be a predictive future of active inflammation. I suspect respirations might be around, could that be related to maybe anxiety, or that could be a sign of, if you're actively inflamed, but you're not having any of your GI symptoms, maybe your respiration rate is kicking up. And then I suspect affect gait speed is you probably slow down when you're not feeling good, right? And so these are all sort of like non-specific surrogate markers of either some subclinical inflammation right now or a future that, you're going to develop symptoms in the future. So just kind of cool. I saw that, and I don't know what this Emerald or Emerald, I was writing it down when I was there, and I probably wrote it down, but I don't know what this actual sensor is. I didn't have a chance to look it up, but it was one of the oral presentations at DDW this year. So it's called Emerald Innovations, from wearable to invisible. So they're doing some pretty cool stuff. So
very cool. What other themes did you find? So we started with diagnostics.
Well, I think we kind of touched on it, Bincy, and we see this, but I think it's pretty known that, right, if you have a pretty cruddy diet, if you're not eating healthy foods, if you're not eating foods that are going to feed a really healthy microbiome, no matter if you get into the real deep basic science about, the actual changes in your microbiome, that you're not going to feel well, but we know that that has been associated with not only disease development as well as risk for relapse of disease. What can you actually fine tune about your diet to prevent that is not entirely clear, but they had some studies that looked at high fat diet being associated with worse colitis, a sulfur-based diet, so low calorie foods, processed meats, low plant intake was associated with an increased risk for Crohn's disease in a patient population that did not have Crohn's. High plant-based diet in Hispanic individuals in one study was associated with lower overall disease activity. So, I think we've known that. We don't want our patients to avoid fiber in certain situations. We want them to be able to have a healthy microbiome and feed that diversity. But I don't know if Bincy, if you saw any other themes around kind of developing disease or risk in diet.
Well, actually, this is all consistent with what we've known previously. I actually did a systematic review. We published a systematic review on diet and the potential for development of IBD. And again, same theme. So we found high polyunsaturated fatty acid intake, high red meat intake, low vegetable intake, low fiber intake, low fruits as well, increased your risk of developing inflammatory bowel disease, both UC and Crohn's. On the opposite, if you had low red meat intake, high fiber, high fruit vegetable intake, low, polyunsaturated fatty acid intake, then you're less likely to develop that. And this is all pre-illness diet studies. Of course, that's just with not just this one, study that was done at DDW or multiple, like we put all of that together. And this was, I think, about 10 years ago. So all that diet studies, it's like even the newer ones is actually confirming what we've known. So it's like the stuff that our parents told us, or mom said, eat your vegetables. Well, as long as you can, eat your vegetables, you should eat them, and not eat so much of the junk food, all of that. So yeah, absolutely.
I set you up for that, Bincy. I knew about your publication. So I'm setting you up for
this is why
being able to do that.
My podcast with Jami. I love it. Well, another big diagnostic thing that I can skip through is, of course, intestinal ultrasound, because when I was doing all the abstract reviews, I typically, over the past several years, I'm always looking at my section is on diagnostic markers and, the markers for IBD. And this year, I think out of, 75 abstracts I reviewed, I feel like 40 of them were on intestinal ultrasound, or at least 38 or something, like about half of it was on intestinal ultrasound. So that I thought that was phenomenal to finally see at our US national meeting, to actually get this on the research, venue there. So, it's been a big thing, because I was like one of the first to do intestinal ultrasound in the US. And I'm like, this is my passion. I just finished doing, I think 10 or 12 patients today, and I was rushing to do this podcast. And I think it's really changed how we really should, are practicing and taking care of our IBD patients. And it's point of care testing. We're able to do it bedside in our clinic. There's no endoscopy required. There's no sedation. There's no fasting required. There's no prep required. There's no pain. We're getting things like right then and there. There's no lab that we have to test and then wait a day or a week to get the results back. We can make decisions right away. And I had to tell you this also because we had a poster there as well. And, what we've been seeing and the other posters and abstracts there kind of all confirming the same thing, how useful this testing healing is. And in our study, we actually looked at, the intestinal ultrasounds that we did in our IBD patients. We also looked at their, lab markers, biomarkers, like fecal calprotectin, lactoferrin levels. And we actually found that our ultrasound found more disease than even when patients that felt obviously clinical remission, because we know the clinical activity scores have not been the greatest to assess how, active a patient's disease is. Despite patients saying they're in clinical remission and lab markers saying that it's normal, we actually still found disease activity on ultrasound. So I think, traditionally the non-invasive methods, without putting everyone through a colonoscopy, may have actually missed ongoing activity in, a certain group of patients. And we're able to see this now. And another component of it, we've all heard about the STRIDE-2 guidelines. We have to get everyone to endoscopic healing, which is great. But on the other end of it, there's a suggestion that we should consider getting our patients to transmural healing in, Crohn's disease, for example. And it's not like our current, this is our exact recommendation, but something as a consideration for future. I have a feeling with more and more data that's coming out, when we presented at DDW with all these abstracts coming out and new research, that maybe our STRIDE-3 guidelines we need to include transmural healing, because the studies are coming out actually show that if you go past endoscopic healing to transmural healing, especially in our Crohn's disease patients, that we're actually seeing even better outcomes for them, right? Because again, Crohn's disease, we've learned in medical school, it's not just a disease of the mucosa, it's transmural. It goes all across the layers of the intestine. So we're only looking inside the lumen, which is important to, look for healing and all of that. We may miss out on any inflammation that's going past it that we can't visually see on the endoscope. So I think this is a very useful tool. Now, traditionally, to look for all of this, we've had to do CT scans and MRIs, which are fine to do, but CT scans require radiation. MRIs are expensive, and it takes 30 minutes to go through the scanner. If you're claustrophobic or if you're obese, there's some limitations to that too, and expense as well. And it's like ultrasound, not very expensive compared to other modalities. There's no radiation involved. The other beautiful thing is that if you have a pregnant patient, they have IBD, we can assess disease activity without putting them through a scope or, a scanner. And the fun part is that they're in their second, trimester, we like to see the baby as well. And I had I have lots of fun with my patients looking at their ultrasound. I always had to say, okay, I'm going to focus on the bowel first, and then we'll play around and check the baby out too. So it's been fun all around.
I was able to attend, and Bincy was my instructor at the Module 1 course. So I am actively getting trained in intestinal ultrasound. So I'm excited to be joining the Mount Sinai group in the summer to go do my Module 2 training. But it's very humbling, right? Because you sort of, we learned colonoscopy a long time ago. And I remember my first day of colonoscopy. I feel like that every time I touch the ultrasound machine, I'm like, I think I found it. So my hope is that I can be able to bring this here to Mayo Clinic in Florida, and we can start to train the next generation to be able to offer this as a diagnostic tool. But yeah, some great science that came out of DDW, 25 abstracts and 10 other presentations surrounding intestinal ultrasound. So we need more people to train people. That's what we need, so that we can start to have more people have access to this and do high quality exams, right? It's not just about having an ultrasound machine, but that you actually know what you're looking for. But yeah, very humbling. So more to come on that. But I'm glad that you guys are doing that over there at Houston Methodist.
Yeah, we have some trainees too. So it's always nice to know how far you've, come along the way when they're struggling. It's like, oh, let me find this for you. It's like, oh my gosh, I can find it now. It's been years into the
They're saying there's a chance for me, Bincy.
Yes. Oh, absolutely. I was the same way. It's just like when we're done with fellowship, it's like, okay, now there's no faculty to take away the scope to help you finish. You have to do it on your own. But the nice thing is, it's an adjunct test. So if you ever have any questions or concerns that you're not sure about an area, you can always do a CT or MRI if needed for that patient. And then you can also use other, adjunct markers to assess, not just like one thing. It's like the patient's symptoms, lab markers, prior endoscopy, prior imaging, your imaging, and then to make sure everything correlates. And if something is not making sense, then you can, do additional testing. Yeah. So it's not like you're just only on your own. So it's okay.
Yeah.
Love the idea of the ultrasound. because I always say my labs lie. They tend to lie. I'm not going to say they're liars 100% of the time, but I would probably go with 90% of the time my labs are liars. So this is exciting time to be a patient with IBD, having
Yeah,
something
there's
like
been
this.
some work outside of just ulcerative colitis and Crohn's. There's been ultrasound that Mount Sinai's done in pouches, looking at about how do you assess pouchitis using ultrasound, and looking at postoperative recurrence. And there's, I think that there's, an opportunity in the future where you can imagine somebody walks into clinic with just abdominal pain and diarrhea, undifferentiated patient, and that routinely a gastroenterologist will be able to use this almost like we use a stethoscope, right? The way the cardiologists have access to their patient's organs via stethoscope, it's kind of the way that, I'll have to, I guess, get my own little portable one that will just follow me around and I can put all my stuff on it. But yeah, there'll be some pretty cool stuff moving forward. I think, one of the things I want to touch on, because I think our patients are actually really excited about some of the new therapeutic options, right? So we have an expanding toolbox that is incredible. And I'll maybe let Bincy touch on, one that she maybe knows a little bit more about. But there were studies that were done looking at mirikizumab, which is an interleukin 23 inhibitor. So it's similar to currently risankizumab, which is approved by the FDA as Skyrizi. But this one, we're hoping for FDA approval for ulcerative colitis indication, in the coming months. There's a little hold on it right now that was unanticipated, but the data that was published or presented at DDW just further, supported this as a really great, excellent therapeutic option. So it'll be a new mechanism per se that's available for patients with ulcerative colitis in the next couple months. And then I'll speak to the most recent FDA approval. There was some data presented at DDW, but the FDA last week approved upadacitinib, Rinvoq, which is currently only available for ulcerative colitis and is now officially the first oral therapy, advanced therapy that we have available for patients with Crohn's disease. So two very exciting things, but I know that Bincy, had attended some meetings about some other therapeutics that are coming.
Yeah, and actually on upadacitinib or Rinvoq, there was a study looking at fistulizing disease, because that's not often studied. Crohn's, right? We always exclude them just to make sure that the drug works in the routine inflammatory Crohn's patient. And upadacitinib actually appeared to be promising in closing fistulas too. So it was really nice. It was actually timely to have that abstract out and it was an oral presentation where we got this drug just recently approved, and we have now data that we can actually share with our patients. Say, you know what, we can actually consider using this for a fistulizing patient. Before, when we had newer drugs coming out, it's like, well, we don't have that data yet. Give us a few more years and we'll know, but we can always try it. I don't have the data to prove it. This is really nice to be able to, have that. And now that's approved, to say, you know what, I think we should try it. We have the data that it does help with closing fistulas, instead of thinking that we would, we just assumed that a drug could work in that. So that was really nice. The other one, this is not yet approved in the US, but, infliximab or Remicade been out forever, right? It's our first biologic, and it's been in IV form. Now there is a sub-Q version that's been approved elsewhere, like in Europe and all that, and they've been using it there without any issues. And we finally have the data from the US study that actually show that it works just as well, from the IV version to the sub-Q version of infliximab. So I thought that was really nice. Now it just is a matter of time for FDA to actually approve it for use in the United States for patients who've been doing fantastic on infliximab, Remicade, or any of the biosimilars. And to say, well, I would like to have the convenience of taking an injection at home. It's going to be every 2-week dosing instead of every 8-week infusion, but subcutaneous, and they can take it at home. So that will be nice, for the future, because currently our FDA is going to be looking at the data to see if they will approve it here. I think in Europe and like Canada, they were, especially in Europe, they were okay with like their studies, but the FDA required a US or another study for that approval. So that's in the works. What else? The other
Sorry.
Yeah, there was one.
No, I was thinking sub-Q. I didn't actually see any studies on the sub-Q vedolizumab at DDW, but we hope in the next year, it's available outside of the US, that we see a currently available FDA-approved therapy, vedolizumab, that might be available for maintenance as an injection instead of an infusion. I'm thinking about those patients that may travel, that need that flexibility, and it showed equal efficacy and safety. So we fingers crossed. I mean, we're gonna have a busy IBD FDA approval season, which is lots of celebrations, lots of naked and famouses, I guess.
Yeah. All right.
Oh, what I was also thinking is, I think one of the things that we anticipate, there were quite a few studies. Right now we have biosimilars for infliximab. We have one biosimilar for adalimumab, and we anticipate what 9 others that are going to come in July potentially. And so there were some studies looking at various adalimumab biosimilars showing similar efficacy, tolerability, and pharmacokinetics, which just means that we can feel comfortable in an IBD population, telling our patients that this medication, if their insurance company has a preferred formulary for a biosimilar, is going to be very similar in all parameters when we use it for their disease. But that's something that our patients and our listeners can anticipate if we start a new adalimumab prescription, that it may not be what they traditionally have thought of as Humira. It may be one of the various other biosimilars. So we hope that we can kind of tame some of the anxiety that patients may have around not starting on that, or what we call the originator, right? Remicade or Humira. But I think it's going to be a way of life moving forward. There's lots of biosimilars that are coming for different medications that are currently FDA approved. So it's something that we have to be comfortable with, and just make sure that we demand that there's data that support use and show tolerability, and that we can potentially use them interchangeably if we need to.
Was there any studies, papers, posters, anything out there that discussed multiple switches? So switches between biosimilars and the safety there. So starting with Remicade, moving to one from one, then over to another.
Yeah, there actually have been studies, I should say, on both Remicade and with Humira as originator, and then the biosimilar versions of those. And so far, it actually looks good. There's not been anything new or any concern that multiple switches has leads to any consequence. Actually, we've seen similar efficacy, similar immunogenicity, meaning the risk of getting anti-drug antibodies against that medication or the biosimilar, because they're all kind of similar in that sense. So we haven't seen anything, which is actually good and also reassuring as well. And I'm glad Jami brought up that the whole biosimilar component in adalimumab, because it is going to be the new future. But I think whenever a new drug, or even if the biosimilars come out, there's that huge anxiety of, I was on X drug for so many years. Now my insurance is mandating to switch to something else. I'm worried. But I think with all the data that we have, and again, it's with not just for IBD studies, but with psoriasis, psoriatic rheumatoid arthritis, like all the indications of these drugs, we have not seen anything to suggest that any of the biosimilars as getting FDA approved are actually worse, because then they wouldn't get FDA approved, right, as a biosimilar. Be similar to the safety and how well the medication works and side effects, all that. So it's very reassuring. I think to the point where if you end up having to switch because of insurance, it's like there's no need to fight it, because fighting it will actually lead to delay in your getting the medication, and you rather just get on the medication. You can continue to do well on whichever biosimilar version of that original drug is.
I think the one difference that I anticipate, and that we'll have to try to work through, is, with infliximab biosimilars, it's hung, it's an infusion. A patient actually probably wouldn't know what the difference was between Remicade or a biosimilar. But with the adalimumab, because especially patients that have been exposed to Humira and, been on it for a while, they're familiar with the pen, they're familiar with the services offered by the company. For them, a biosimilar is not just a different bag hanging, right? It's a different pen, it's a different color, it's a different mechanism at which it injects. Some of the biosimilars are not going to be citrate free, which we've come to expect out of our adalimumab, our Humira. So I think that there has to be, and I think we'll probably work through some of those challenges. For a new patient, they're not going to know any different, right? They don't know what Humira was like. But for a patient that has been exposed to Humira and then is forced to switch to a medication that, for all intents and purposes, efficacy, safety, pharmacokinetics, they're all the same, but the patient experience isn't the same, right? And so that I think we really need to take into account and ensure that we're supporting our patients through those switches. Might be a little bit more anxiety provoking than infliximab, which again, somebody could have switched the bag and you would have had no idea, but you can't pretend that the pen looks the same, and they can't look the same because they have proprietary sort of mechanisms. So I think that's something that I anticipate come July, that we'll have to have sort of some scripting to work through that with patients, and train our nursing staff to be very familiar with now 9 different products, all with the same mechanism, but all look very different and have different support services and have different teachings, right? How to inject pen A versus pen B may be very different, and they're different doses, actually, concentration, so the amount of volume that goes in. So I think that there's going to be some things that we'll have to, as a healthcare community, come up with some very standard scripting around, so that our teams are prepared for those patients calling in that clearly are going to feel different around their drug experience.
Yeah, I had heard that one of the adalimumab ones, like the current Humira has the needle is entirely enclosed in the pen, so you can't see it. So you put it on your skin, you inject, but that one of the biosimilars is just a needle. And so you'd also have to like sort of get your head around seeing the needle versus not seeing the needle. There's probably some psychological barriers there for some folks, for sure.
Yeah, I think that that's something we have to consider, but I certainly believe in the science behind it. It's just more of the kind of psychosocial aspect to those changes. I don't know, I'm trying to think of other themes. I think there's a lot of stuff around anxiety and depression, which we know. A couple posters actually from some of my colleagues at Michigan about how, we know that patients have anxiety and depression. When you're in a hospital, you're sort of this captive audience where we have opportunities to ask you important questions that we maybe didn't have time to do in clinic. And it's not happening as much as it should. So they actually showed very low rates of screening for anxiety depression in the hospital, which is where really an opportunity to be able to identify those as illnesses or comorbidities that our patients struggle with, that maybe they're getting under recognized, under treated for. Focus on social determinants of health, social vulnerability, the impact of being socially vulnerable, which is defined by a lot of factors, but lack of transportation or being able to access your provider actually also results in lack of access to your medicines. So it's not even just being able to be seen by a doctor, it's that you now are limited in your access to therapies. So those are important things that I think we as healthcare providers need to recognize about our patients and identify them, because they're the most at risk to have adverse events, be undertreated. So I think that those are some important things and work that came out of some of the posters that I saw.
Jami, there was one I wanted to get your thought too, because this question came up in clinic today with one of my patients, actually. The whole concept of, we usually leave surgery as kind of the last resort, for our patients that have, we call medically refractory disease. We've tried every medicine known to man and they're still not getting better. And then we go ahead and do surgery. Well, in ulcerative colitis patients, that's one thing that, we kind of aim for, because everyone wants to leave and keep their colons for sure. And of course, we try medical therapy for majority of our patients. And if it doesn't work, then we'll go for colectomy. But in the Crohn's patient, well, in general, we're always like, oh, we got to stop, we can't do surgery because we can't just take the entire small bowel and colon out. So we want to reserve that for later. And typically we do everything we can medically to take care of, especially the ileocolonic, area where most of Crohn's patients have their disease, the end of the ileum to the right colon, and keep trying until it's just too late or they get scarring, and then we take that and resect it out. But studies are suggesting that maybe we could do the surgery initially, take out that disease burden, and maybe our patients will do well instead of doing medical therapy and waiting till they fail before going into surgery. That question actually came up in my clinic today, and of course you have someone who's like responded beautifully to medical therapy, and it's like, well, that would have been a good question before you did really well on medical therapy. But that was something, and we had this long discussion, especially since at DDW there was a study that looked into all of this, that it's not completely out of the picture, or if this medication doesn't work, then we can still consider it. Often patients are in like jumping to say, oh my gosh, open me up and take part of my intestines out. But I think this is a different way of thinking than we've thought about like years back. It may be reasonable to resect a certain section of this out and reconnect, and maybe these patients will do well without being on therapy for quite a long time. Is it going to be a year? It can be 5 years or 10 years, that we don't know. And maybe now we can use like CDPath to put all together and say, hey, what will be the new prognosis for this patient if we take out this disease burden too?
There was the one small study that had been done previously, and I think it was imperfect and be able to draw conclusions from. But I think the DDW study really looked at, early surgery versus, in this particular study, they looked at TNF. So it wasn't looking at a lot of our other biologics that we now have available to us. But, you're right. I think about those patients that we struggle with, they have limited ileal disease, maybe a little bit of right colon disease. They haven't developed a fistula or a stricture, but we just can't get that inflammatory burden under control. And we keep cycling through. And now we're on our potentially, because as our toolbox gets bigger, right, the challenge is now we have more options in a positive way, but in a negative way, just because there's options doesn't mean that we should potentially be using them in that way. And I think, this study really highlights that surgery should always be on the menu. It should not be the last. balanced, right? It should be an equal discussion of surgical versus medical approach, and it should be really what fits best for that patient. I'll share a story, thinking of a patient who, didn't want to be on medical therapy, had inflammatory disease, and desired pregnancy. And so, inflammatory disease, get on medicines, wait for remission, potentially do another scope, waiting, 6 months, pushing back that timeline that's really important for a patient. So I think this just highlights how important it is to ask about patients' goals. And this particular patient's goal was, I need to be pregnant in the next year. So we actually opted for surgery for this patient, and we opted for no medicines after surgery because we deemed her to be fairly low risk. Now, we sometimes use antibiotics after surgery to reduce risk of recurrence. But in this particular patient, she met the goals, which is, she's going to get resection of disease. She's going to be, quote, surgically cured. And I hate using that word, but really put into surgical remission. Then we're going to monitor her for any signs of early recurrence. My hope is that she's going to get pregnant easily and then be through pregnancy. And while we know that most of our therapies are safe and we feel comfortable using them in pregnancy, of course, no therapy is better than therapy if it's not indicated, right? And so in this particular patient, she'll get pregnant and not be on therapy, which is really important for her during pregnancy. And that was able to be achieved by early surgery. So I think that there's definitely opportunities where we can consider early surgery versus, cycling through the third or the fourth medication, or even starting the first medication, right? Maybe surgery is the right answer up front in that particular individual.
I sometimes say that I was lucky to be sick when I was because there weren't options. It was before biologics. And so I did have to have surgery very quickly after my diagnosis. And I was able to go so long without medication and, able to manage it. And so I don't know what that would have been like if there was medications, right? I could have spent those past 18 years just cycling through as medications became available. So I don't know what that would have been like, but I often say how I feel very fortunate to have been diagnosed when I was, because I did have to have surgery and it did give me a quality of life I probably wouldn't have had.
I think that's excellent perspective, Robin, because, right. Sometimes, we have so many choices now, which is such an incredible blessing for our patients. But, when you have one more medicine to try, it doesn't always mean you should try it, right? If the writing is on the wall and surgery is very clearly the right answer, just because there's another medicine, a new mechanism, something that just got approved by the FDA, doesn't always mean that that's the right answer. Right. Because, you're right. It really creates an opportunity for physicians and patients to partner to figure out what's right for that particular patient, not what's just Crohn's disease, this is the treatment prescription, but what is right for your Crohn's, what is right for your colitis. And I've had patients recently opt for surgery fairly early in a treatment course because they've decided that they want to take control back, and they've been struggling, even though they haven't tried every therapy that's available, they've been struggling and they want to have control back of their disease. And I'm very supportive of that because surgery is a very reasonable option, and it doesn't have to be the last option when everything else has not provided anti-inflammatory relief.
And I can tell you, on the other hand, though, I had some patients, from a mental standpoint, she was like, I want to try this medication. I want to try this last one. And if this doesn't work, then I'm going to feel ready mentally to go ahead and have surgery, because I'll know that when I won't have any regrets that, oh, I should have tried this one. It just came out. And so we tried it. We gave it up to about 6 months. And that time she said, you know what? Thank you for letting me try it, because I feel better going into surgery now, that I won't have any regrets thinking, oh my gosh, what if that last medication would have worked for me too? So, it can go both ways. On the other hand, from a medical standpoint, I've actually had several patients who, were trying to avoid surgery because of multiple reasons, from a patient perspective or from a medical perspective or comorbidities perspective. But then the disease was so stubborn. And so I was putting them on more and more medications or combining them, combination therapies, increasing their dose more than, standard dosing. And sure, they would get better, but it would still, like, if we go endoscopically and look for healing, it wouldn't completely heal up. And we made the decision, what, it's a certain area, let's go ahead and resect this out and reconnect you back and see how you do. And that made a huge difference to them from taking the disease burden out. And then I was able to reduce all of their medications, or, get them off combination therapy, just monotherapy on one drug alone. And it made a huge difference. So sometimes surgery is not like the last resort. It should be really combined with medical therapy to have optimal optimal treatment goals for our patients too.
I like the way that you said that, Bincy, is using it as sort of a combination approach to care and not as an alternative to care. I think, yeah, just reframing the way that we think about surgery and our patients think about surgery. I think a lot of it is because when we see these, second, third opinions, no one has actually mentioned surgery. So when you bring up surgery, it sounds like you're saying something absolutely crazy, right? Because why has no one ever told me that surgery is an option, So I think that it's, if there's non-patient listeners to your podcast that are, gastroenterologists that see, IBD patients, is bring up surgery, put it on the list, that surgery is always is an option. It can be an option now. It can be an option 6 months from now. It can be an option a year from now, but it is an option, and very much, having that, normalizing that discussion, I think, is the most important.
And I also tell my patients that, here's the number, or let me go ahead and refer. Now, just because you see them doesn't mean that they're going to operate right away the same day you see them in clinic. Have them answer all your questions. Sometimes, we've gone through a lot of our patients going through surgery and all this, but sometimes they have very technical questions. I say, well, the patients I've seen and sent to the surgeon, they do it this way. But I also tell them, go ask them those specific details, because they would have done that specific surgery that you're going to end up having on multiple patients, and they can answer questions regarding healing process, time out of work or school, the things that they need to be looking out for from that. And I think they feel better. It's like, okay, I have to go to the surgeon, but doesn't mean it's going to be a surgery the day they get their appointment. It's really to have that discussion. And actually another discussion that happened today in clinic too, where we talk about how elective surgery is always better than emergent surgery. And when you go and see the surgeon, you talk about it and have a plan of, okay, this is, I think it's going to be a good idea. I'm not feeling terrible. I'm not in the hospital, with an emergency situation like a perforation or obstruction. Things have calmed down now, but I know the disease is still there. I'm feeling okay. I'm feeling healthy enough. We have enough nutrition in them that when they do go for surgery, that it's going to be as optimal as possible, rather than, oh my gosh, we got to go in for surgery emergently, and then nutrition's terrible. They're anemic, their albumin's low, all of their parameters for a good outcome is actually terrible. And so we wanted to optimize everything and do things electively as well. I think it's very important. We have that discussion all the time, that elective surgery is 10, 20, 100 times better, I should say, than emergent or even urgent surgery.
But I think what you are talking about and highlighting is the importance of you as providers and the patients really having that shared and trusted relationship between you, so that you are a partner with them in making these decisions and giving them their options in a way that's they can take in at that time. Because I'm sure sometimes if somebody's newly diagnosed, you're not like, here's 20 medicines and surgery that we can talk about, but helping to guide them, but still making them a big part of that decision to be able to say, I'm ready for this or I'm not ready for this. I think that's really, really important. And if patients don't have that, I think it's definitely something to seek. This may get completely cut out because this is mainly a curiosity question, but I'm curious just anecdotally if you see a difference in adherence to medication between injections, infusions.
I think Susie Kane has done some studies around, adherence to these things. It's interesting. Obviously, more frequent you have to inject something is probably going to be less adherent than the least frequent. I think that infusions, it's easier to track adherence, because we know when a patient doesn't schedule, we know when a patient doesn't show up for an infusion. The nice thing is some of the industry companies and some of the specialty pharmacies will notify us when they're supposed to be on a drug every 8 weeks and you've not picked up or you've not shipped the drug in the 8 weeks, you haven't ordered it, whatever that might be, they'll notify us. But I think, I personally, as somebody who should be taking like a vitamin every day, I can't remember to save my life to take something every day. I mean, it's just, even I have a pill container too. So while I know patients have desired oral therapy, some of our new therapies actually coming out are oral. I'd rather take something once every 8 weeks or, 4 weeks or even every 2 weeks than have to remember to take something every single day. But that doesn't mean that we shouldn't use these oral therapies that are very effective. But I know me personally is I'd be much better about once every 8 weeks than having to remember to take something every day. But I don't know, Bincy, what do you think? If you were...
Yeah, I mean, it varies so much. I have had some patients who they'll go for infusions, are going to an outside facility that they don't necessarily tell us that they canceled until 3 or 6 months later. Then, who cares? cares? It doesn't matter anymore, right? Then we gotta work on fixing that. But on the other hand, I have some patients who, especially when you had to dose adjust them, that, oh, I forgot to take it this day. And I have others who will be like, oh, I have it on my calendar and my alarm goes off and I am really adherent to it. I'm like the best patient you could ever have. I'm like, okay, I'll take it. And then, so it really varies. It doesn't necessarily mean it's, oral versus sub-Q versus IV. It's all patient's preference and how well they remember. And I've had some who, we were trying to go from twice a day to like once a day dose. I'm like, no, I have my schedule down pat. I don't want to change it. I'm going to stick with this. I'm like, okay, whatever works for you, as long as you get your medicines in time, that's completely fine. So it's so variable. I haven't seen like one over another. Yeah.
Thanks.
This has been so fascinating, honestly. You're right. Jami, did you say at the beginning that we could talk for hours about this? I could listen to you talk about it for hours, honestly. I don't want to let you go, but thank you so much for coming on the show. Thank you, everybody, for listening, and cheers, everybody.
Cheers. Well, cheers to all these approvals and opportunities and so much great science that our colleagues are presenting at these conferences that we get to talk about. Yes, we could talk for hours. So let's do a part 2 with a Bincy Jami show, okay?
Oh my God. That's great. We'll just let you guys talk.
There's
the
a
whole
nice
time.
ring to it, the Bincy Jami show. I like it.
Yeah.
If you liked this episode, please rate, review, subscribe, and even better, share it with your friends. Cheers.